cardiovascular pathology, neurocomplex tachycardias, including atrial fibrillation and paroxysmal supraventricular tachycardia. All right, so I skipped over multifocal atrial tachycardia. It really isn't that important. I don't think I got a single question on it. I don't even know if I'm allowed to say this, but someone like came and lectured us at Neomed and he talked about it like one time, but that was like the only time that I saw it. And honestly, I really wouldn't spend time on it. So anyway, we're going to just start with atrial flutter. All right, sweet. So atrial flutter, the way that you remember this, okay, so once again, it's the narrow complex tachycardia. So you're going to have narrow QRS waves, okay? But the way that I remember this is that you have an equal RR interval. Okay, so you have equal RR intervals. Unlike atrial fibrillation, where all the RR intervals are different, right? Because it's like boom, 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 boom. So that's atrial fibrillation, right? All of them are just random. The RR intervals are random. The atrial flutter is normal. Boom, 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 right? So it's normal heartbeat. But in between, we have a sawtooth pattern. So if you ever see a sawtooth appearance, take a look at it. It's something that you're going to see a lot, and you're going to be like, wow, that's actually very easy to understand. I could totally spot that out, okay? Look, if you see sawtooth, and then you go and you look at your RR intervals, and they're equal, then you know you're dealing with atrial flutter, okay? So the first thing you look for is are the RR intervals equal? If yes, then look, if you see sawtooth, okay, potential sawtooth, cool. We're leaning towards atrial flutter, okay? Now, moving forward is what do we do? Okay, so how do we treat this for atrial flutter? Okay, it's very easy to specifically ablate, okay, the area between the tricuspid annulus and the IVC, okay, because that is where our abnormal electrical current is coming from for atrial flutter. And this is unique to atrial flutter because we already talked about AFib. We have to ablate the pulmonary vein ostia. That's where our irregular current is coming from in atrial fibrillation. But for atrial flutter, the irregular current is coming between the tricuspid annulus and the IVC. So if you ever see tricuspid annulus, start thinking about atrial flutter, okay? They love to say that. So those are the three things. RR intervals are equal and equivalent to one another. You have a sawtooth pattern, and you're going to be ablating between the tricuspid annulus and the IVC. Next is paroxysmal supraventricular tachycardia, okay? So for this, what we have to understand is that there's a re-entrant tract between the atria and the ventricle, okay? And that's the most often what's occurring with paroxysmal supraventricular tachycardia. And since there is a re-entrant tract, it's most commonly in the AV node, okay? And now what does that mean to me, okay? I just said re-entrant tract between the atria and ventricle is most commonly in the AV node. So what happens is that normally, as we know, the SA node is going to send the electrical signal to the AV node, and the AV node has a little break, okay? And the break is in order for the ventricle to fill, okay, to fully fill. And then once the ventricle fully fills, the AV node is going to go and continue on the pathway, okay? Now, if we have a re-entrant path, okay, a re-entrant tract between the atria and the ventricle, most commonly in the AV node, right, then we're going to be dealing with paroxysmal supraventricular tachycardia. And so what does this mean? It just means that we have intermittent tachycardia, okay, due to this re-entrant tract, and the patients are going to present as young patients with like a feeling of lightheadedness and palpitations. Okay, so they're gonna get sudden onset palpitations because of that sudden onset tachycardia through that re-entrant tract, and then they're gonna get like lightheadedness, okay? That's all you need to know, okay? The patients will not pass out. Don't think about passing out. That's something else. The syncopal episodes just means passing out. They do not have syncopal episodes and paroxysmal supraventricular tachycardia. And the patients are gonna be looking at buried P waves with narrow QRS complexes. So take a look at your EKG for paroxysmal supraventricular tachycardia, and you'll see buried P waves with narrow QRS complexes, okay? But overall, the patient's going to present, young patient, they feel sudden onset palpitations and lightheadedness, and they're going to say something about a re-entrant tract involving the AV node, okay? Now, last but not least is Wolff-Parkinson-White syndrome. I'm going to make its own video for it because I think it's really, really high yield and important for you to know distinctively what it is, but I'm going to help compare and contrast it to the others.